Hi, my name is Atif Darush, professor and consultant of obstetrics and gynecology. In this lecture, I would like to highlight type 3 myoma. What's the best treatment of such a case if you are confronted with a case of type 3 myoma? You know that the FIGO 2011 classification put leiomyoma as one of the main causes of palm coin of abnormal uterine bleeding. And these leiomyomata were classified into 8 groups, and the subgroup 3 is the intramural myoma, but has a contact with the endometrium, but 100% it is intramural. And in the modification or revision in 2018, they put the myoma, which is completely intramural, just contacting the endometrium, as a submucous myoma. They considered it as a submucous myoma, like type 2 myoma, which is more than 50% intramural and has a contact with the endometrium. So the difference between 2 and 3 is that the 3 is completely intramural. And why they put it as a submucous myoma? This is the first question. Because some of those cases coming with symptoms, and these symptoms include abnormal uterine bleeding, pregnancy complications due to defective blood supply to the placenta, inadequate oxygenation, necrosis, and inflammation, with increased risk of preterm labor or recurrent pregnancy loss. And some of them are coming with infertility. You don't find any cause of infertility except a type 3 myoma. So these maybe myomata may be cause of infertility. And you know, the fibroid-related infertility causes are too many, including distortion of the endometrial cavity, thicker capsule, impaired endometrial receptivity, hormonal paracrine and molecular change, increased uterine contractility, and impaired endometrial and myometrial blood supply. A recent review article added many other causes of infertility in fibroid patients, including pelvic pain, dyspareunia, and prolonged and heavy menstrual bleeding that interferes with sexual arousal, and as a consequence, the frequency of intercourse is decreased. Also, change in the vaginouterine microbiome, disturbed peristalsis, physical compression with the tubes, apparent angiogenesis, and altered endometrial blood supply, molecular change in the endometrium, or disturbed level of inflammation and autophagy. So these are possible mechanisms of infertility-related causes of type 3 myoma. Moreover, type 3 and IVF studies found that in a meta-analysis and systematic review, found that patients with type 3 myoma, which were 324 patients with FIGO type 3 myoma, had significantly associated with decreased implantation rate, decreased cumulative pregnancy rate, and decreased live birth rate, with deleterious effect on the outcome of IVF. And this deleterious effect increases further with increased size and number if compared to other patients without myoma. So it seems logical to add this type 3 to the category of submucous with type 2, 1, and 0 due to the symptomatology, including abnormal bleeding, infertility, and pregnancy-related complications. But they considered the symptoms only to add this type to the submucous group. And they mentioned that you can diagnose or distinct between the type 2 and 3 by, of course, by ultrasound, by MRI. And during hysteroscopy, they mentioned that you have to decrease the pressure a little bit to make this intramural part a little bit bulging into the cavity to see it. But actually, this test is not practical in some cases, which are completely intramural or of big size. So the drawbacks of this consideration of type 3 as a submucous myoma include no guidelines available and the best surgical approach. They focused on the diagnosis only and symptom only, but they did not focus on how to treat such a case without comment on the myoma size, the number, the residual myometrial thickness, and proximity to this Darwish triad, which is the corneal ends of the uterus and fallopian tubes. And actually, there is a controversy regarding the before IVF ICSI. Should we excise or not excise an intramural myoma of 3 to 4 centimeters before embryo transfer? And there are two teams mentioned in a debate in the fertility sterility. One of the teams against surgical excision is Dr. Monroe, who is the first author of the WHO publication and WHO revision in 2018. He's against surgical treatment of such a myoma in cases of infertility. So they considered it a submucous at the level of symptomatology, but regarding treatment, they are against surgical removal because the surgical removal of such a type of myoma is a risky procedure with limited evidence of benefit, possible post-operative adhesions, and delayed wound healing. In addition to, you have to consider fertility preservation of such a case. On the other side, the pros of doing the operation of the intramural myoma more than 3 to 4 centimeters because it has negative impact on the reproduction and the obstetric outcome, which improves markedly after the operation. And there are many experienced laparoscopists can do this procedure. So again, the FIGO classification put type 3 as submucous based on symptomatology. But regarding line of treatment, the first author is against surgical treatment in infertility patients subjected to IVF ICSI. So what are the lines of treating type 3? If no symptom, no treatment, of course. Some studies focused on pharmacological treatment like gene-rich agonists and others without solid evidence. Some studies mention that we can insert levonorgestrel intrauterine system or uterine artery embolization or high-intensity focused ultrasound in cases of abnormal uterine bleeding. And of course, those cases are not willing to have a baby. But for infertile cases, they recommended publications, despite being minimal and scarce, they are either hysteroscopic myomectomy, laparoscopic myomectomy, or open myomectomy. Some studies mention that preoperative hormonal treatment like gene-rich agonists, progestogens, or others may facilitate surgical procedure, minimize blood loss, but there is no sufficient evidence in the literature. In addition, they can reduce distension media intravasation as well. Now we have to focus on hysteroscopic myomectomy of type 3, which is completely intramural, just has a contact with endometrium. The primary goal is to avoid open or laparoscopic myomectomy. And if we succeed to excise such a myoma via hysteroscopy, this is advantageous because the myoma has proximity to the endometrium. So the most accessible site to enter to remove this myoma is the endometrial cavity. So we save the myometrial fibers than other known surgical approaches. In such a case, we respect the pseudocapsule, and of course, pseudocapsule is important for healing and has many functions with less myometrial damage. And of course, because we are coming from the endometrial cavity, if you are using cold loop myomectomy, this preserves the myometrial and pseudocapsule tissues from damage by the electrosurgery, and with less post-surgical synechia formation, as mentioned in some review articles. But to do hysteroscopic myomectomy of type 3 without any bulge inside the endometrial cavity, there are certain technical tricks that you should put in mind. Number one, you should be an experienced hysteroscopist. You should be experienced with intrauterine surgery of advanced intrauterine adhesions, adhesolysis, myoma of big size, and so on. Now, the beginners are not allowed to do hysteroscopic myomectomy of type 3 myoma because it's very difficult to remove by hysteroscopy for a beginner. Number two, you should have a consent from the patient that I may fail even despite being experienced hysteroscopist or intrauterine surgeon. I may fail to remove this fibroid in one session. You should consent for 2 sessions or even open surgery whenever needed. And you have to minimize endometrial damage because the more endometrial damage to get the myoma, the more adhesion formation, and this is not good for fertility patients. You have to identify and preserve the pseudocapsule, and this is important because pseudocapsule is a landmark of the fibroid and preserves myometrial tissue. Don't go through the myometrium too deep to destroy it, and this can be achieved by blunt dissection or combined electrosurgery and blunt surgery. In this short video, this is actually type 2 myoma, but big size. But I would like to show you the pseudocapsule, how to reach the pseudocapsule. Here you are excising the myoma, even 2 or type 2 or type 3. And then you will find the pseudocapsule. And this pseudocapsule, this colorless, fibrous tissue, you see it. Once you reach it, you have to know that the myoma is completely removed, and you have to preserve this pseudocapsule if you are doing blunt dissection or with electrosurgery. And this is again how to go through the myometrium and cutting the endometrium at the base of the myoma to reach the pseudocapsule and to excise the fibroid. More details on how to preserve pseudocapsule are found in this lecture on reproductive versus conventional hysteroscopic myomectomy with this link on this channel. Again, another trick is to monitor your procedure. Some doctors are go to the hysteroscopic myomectomy based on previous ultrasound or previous MRI. This is not completely safe. You have to follow your operation by real-time ultrasound put on the abdomen or transrectal ultrasound to monitor your procedure to see the loop of the resectoscope, where is it and what is the distance between the tip of the instrument and the serosa of the uterus to avoid unintentional perforation. We described a modified technique for large submucous myomata, which applies to the type 3 by making a vertical linear incision over the site of the myoma with injection of intravenous diluted ergometrin to stimulate the non-pregnant uterus to make contractions and make it extruded to the endometrial cavity to become more submucous, minimize pressure to become submucous. And at the base of the myoma, we can use the loop, and we bend the loop to be 135 degrees, not 90 degrees, to be able to go behind the myoma and to make circumferential excision of the myoma with preservation of the pseudocapsule, as I told you. And this is an example. We bend the loop to be 135 degrees, not 90 degrees, with the horizontal plane to go behind the base of the myoma and to cut this part of the endometrium to reach the base of the myoma and to reach to the pseudocapsule. And this step is essential to separate it. And you can use blunt dissection, alternating blunt dissection and electrosurgery to dissect the base of the myoma from the myometrium with preservation of the pseudocapsule. This step is essential. Alternating blunt and sharp dissection, alternating blunt and electrosurgery is considered a key of success of complete excision. Some authors mention that cold loop using a special strong loop for dissection, blunt dissection without using electrosurgery is recommended in such a case. If we do histoscopic myomectomy of this type 3 myoma or even type 2, the myometrial thickness between the myoma and serosa gradually increases significantly after this procedure, and the thickness of the opposite wall also increases. This has been found in a study on the change of the myometrial thickness due to hysteroscopic resection. So hysteroscopic resection of deeply infiltrating submucous myoma is beneficial in reconstruction of the uterus and restoration of the normal myometrial thickness. However, nonetheless, we have to know that hysteroscopic myomectomy of type 3 may be associated with many serious problems. The first problem is failed access. When you go by hysteroscope, you don't see anything. You will find a fine endometrial cavity because the myoma is not bulging. Okay, by ultrasound, it's contacting the endometrium, by MRI contacting endometrium, but hysteroscopically, I cannot see it. And even if I decrease the pressure, I cannot see it. I see just bleeding due to decreased pressure. So failed access is one of the main problems of the hysteroscopic myomectomy of type 3. And of course, danger of access is very high. And in one study, they failed to remove the myoma of type 3, and they made hysterectomy for 2 patients and recurrence of bleeding that required open myomectomy in 1 patient and intrauterine adhesions in 3 patients after trial of hysteroscopic myomectomy. So it is not a completely safe procedure. Another systematic review and meta-analysis on 3 studies out of 261 studies found that some patients required additional procedures, and some patients developed intrauterine synechia. However, the cumulative pregnancy live birth rate increased after the myomectomy of type 3. So the drawbacks of hysteroscopic myomectomy of type 3, including lengthy procedure, possible perforation, big endometrial defect, and fluid overload, in addition to possible 2 sessions of laparoscopy or laparotomy, requirement of high level of experience. In a previous lecture on uterine niche, I highlighted the importance of residual myometrial thickness, which is essential for selection of hysteroscopy or other alternative repair techniques of uterine niche. The same applies here. The residual myometrial thickness is essential to guide you if you can do it hysteroscopically, or better to do laparoscopically. And also you can find a lecture on how to do laparoscopic approach on submucous fibroid. So don't ignore the role of laparoscopy if the residual myometrial thickness is low, and if it is near to the corneal ends, to avoid destruction of the Darwish triad and fallopian tube. It's a safe procedure with hemostasis, with good visualization, with good suturing and adhesion prevention, with a minimized risk of endometrial damage and subsequent intrauterine synechia. So we can conclude that the FIGO revision of 2018 put this type 3 myoma as submucous based on symptomatology, but they did not put a plan for management. So there is no universally accepted best treatment of type 3 fibroid. You have to mention that there is a confusion in the clinical practice based on the 2018 revision, because many doctors go to hysteroscopic resection of this bad type of fibroid without any intrauterine bulge, and many complications occurred, including immediate complications and late complications. So we recommend that if these revisions were made based on the symptomatology, okay, this is good, but you should have a joint meeting with experienced laparoscopic and hysteroscopic surgical societies, and to solve the problems of access, problems of the surgical treatment, individualization. If you have a type 3 near the Darroch triad or the fundus, differs from anterior wall or posterior wall. If it is 3 centimeters, differs from 5 centimeters. If it is vascular, differs from calcified, and so on. So they have to have a stratification or a management plan in the era of precision medicine. And actually, this revision lacks comments on the appropriate myoma site suitable for excision, lacks comments on the impact of proximity to serosa, on the residual myometrial thickness, on the proximity to Darroch triad. As I told you, there is no guidelines available. The best surgical approach is not yet clarified due to lack of international guidelines or research, and waiting for more studies, waiting for the societies to highlight the management plan and put an algorithm based on these findings. We have a publication on the problems of putting this type as a submucus. It goes to publication in the future. Thank you very much.